Welcome to today's podcast on MedSynapse, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host, Dr. Smarika Bhatt, and today we are privileged to talk to medical expert Dr. Veenesh Selvaratnam. Dr. Veenesh Selvaratnam is a renowned consultant orthopedic hip and knee surgeon practicing at University Malaya Specialist Center and in University Malaya Medical Center in Kuala Lumpur, Malaysia. Dr. Veenesh is at the forefront of robotic hip and knee joint replacement surgery. He completed all the orthopedics trainings in UK, including prestigious hip and knee fellowship in Exeter, Ringston, and Bristol. He has also been selected and completed his first effort robotic traveling fellowship in Germany, France, and UK. He is the robotic fellowship trained and certified hip and knee replacement consultant orthopedic surgeon. Welcome, Dr. Veenesh, to the podcast. We are excited to have a conversation with you.
Thank you. Good to be back.
So let's start our first question with, given your expertise at center like Ringston Unit and Exeter Hip Unit, what specific pre-operative planning protocols have you found most effective in managing bone loss classifications and implant selection for complex revision cases, particularly in the context of severe osteolysis?
So I think for this kind of cases, first of all, talking regards to hip and knee revision surgeries. So I think if the patient has got a significant bone loss, I think the first of all is going back to basics, taking a good history and examination of the patient. You just need to know when was the hip and knee replacement done, or the hip or the knee replacement done, whether the patient had any complications early on from a hip and knee replacement, especially infection really. So even though a patient comes in later on with severe osteolysis, the first thing to rule out is still an infection really. You just want to know what was the indication for the joint replacement at the initial stages. And I think so first of all, so very important to take a history, just to make sure they're fit enough for another big procedure, and then examination of the patient. And then we start off with a basic investigation. So you check the patient's routine bloods, including the full blood count, check the inflammatory markers, CRP, ESR, just make sure the inflammatory markers is not raised. And then even though the inflammatory markers are not raised, I routinely exclude an infection in these revision cases, because revision cases are big cases, and infection is sometimes often missed or often not detected. So I routinely aspirate my knees and hips myself. So the hips, I take them to theater and do it under image intensifier to get a sample and send them off for microbiology. So microbiology culture and sensitivities, I check it. I send it off for fungal to make sure there's no fungal infection, TB, as well as cytology as well. And for microbiology, I routinely send it off in blood culture bottles. So I yield, so that the yield is better with in a culture bottle. So as soon as infection is ruled out, then is depending on how bad the osteolysis is, or how bad the defect is, and the different treatment options for various defects. If there's a lot of, let's say for the example of the knee, if there's significant defects in the knee, in the femoral component, or in the tibial component. So if they have a lot of defects, they need to have a revision kind of implant. So either a semi-constrained, like a condylar constrained knee replacement, or a hinge knee replacement, and to address the defect, depending on what kind of defect, how bad the defect is, you either use a cone on the tibial side or the femoral side. Some patients may need augmentation as well, with augments from the revision system. And if the defect is big enough, so obviously they'll need stems up the femur and down the tibia as well. And so these are things that we can use metal augments. So sometimes even can also use bone grafting in the knee. But I do a lot of bone grafting in the hip, especially the acetabular component. So if there's a defect or it's a severe osteolysis on the acetabular side of the hip, again after infection has been ruled out, I do a lot of infection bone grafting for the acetabular component. And most of the time for the femoral side, I sometimes do a femoral impaction bone grafting as well. But I think now our revision implants for the hips are so good that I think you can get away most of the time with with the revision components for the on the femoral side. And obviously, if the defect or the osteolysis is very severe on the femoral side, then you may use an endoprosthesis, such as a proximal femoral replacement, or on the femoral side distally, if there's a knee replacement, then a distal femur replacement, depending on what the severity is as well. So I mean, that's how I manage these patients with severe osteolysis.
Okay, that was such a vivid description. So, could you discuss your decision-making process when choosing between modular and monolithic stems in femoral revision cases, especially in situations with extensive metaphyseal bone loss, or what factors that influences your choice of fixation strategies?
So on the femoral side, again, it depends what's the reason we're doing the revision. If it's just for aseptic osteolysis, so there's no infection. If I normally use a modular kind of a stem, because I think with a modular kind of stem, you can restore the leg lengths better, you can restore the offset better, and you can get better stability, as well as you can actually change, or you can actually control the antiversion. So basically, I normally fix the acetabular side of the hip first of all, and then you need to do a trial once you put your stem in, and depending on the stability or the leg length as well, you can assess them intraoperatively. So I think the modular components are much better for or I routinely use them because I feel it's much better as well to try and get a good or a perfect offset stability, as well as a leg length as well. And also, if you use a modular component, the patient has got any problems later on, then you can also just change the modular neck of the implant rather than taking off the whole implant if the distal aspect of the stem is intact. With a non-modular type, I mean, I don't routinely use them, but there are many different brands out there. But I think sometimes it's more difficult to actually try and maintain or try and get stability, offset, and length. But actually, both of them have got pros and cons. So I think it's very surgeon dependent. But as I said earlier on, I prefer using the modular type of implants for my revision setting. But also that's also for, I mean, that's in cases which are aseptic kind of cases. But also don't forget that you can also use cemented implants as well for the revision side. And I use a lot of I do a lot of single stage revisions for infections of the hip. I use something called Kuma's construct, which I learned actually from the Exeter hip unit, essentially using the Exeter stems and a standard cemented cup to treat infections by putting a lot of antibiotics inside the bone cement, and treating it like a single stage revision as well. So this the more than that in regards to revision. So that's about the femoral stem.
So, Dr. Veenesh, based on your experience across multiple prestigious units, what specific modification have you made to your surgical techniques when dealing with chronic periprosthetic joint infection requiring two-stage revisions, or particularly regarding space designs and antibiotic protocols?
Okay, so I think that's very important. I think infection. So you need infection is a big burden to the healthcare worldwide, really, especially with joint replacement. So I think we normally quote our patient about a 1% risk of periprosthetic joint infections around the hip and the knee as well, with regards to lifelong infection risk. So if I see a patient, let's say if I see a patient who comes in after a hip replacement, a patient comes in with pain, and you suspect and infection of the hip. So first of all, I think, as I said early on, start with basics, a history, examination, routine blood investigation for inflammatory markers, infection markers, and the plain radiograph. And if I suspect an infection, I routinely take the patients myself to theater, and I aspirate it myself under image intensifier. And I send them off for microscopic culture and sensitivities. I also send them for fungal TB, and I send a cytology sample as well. And I said this are best, the microbiology samples are best sent in backpack bottles, which are blood culture bottles, as the yield is much better. And so these patients, if they're not acutely unwell, if they're acutely unwell, then you need an urgent, at least a surgical debridement to get the load down. But if they're not acutely unwell, most of these patients have just got a chronic infection. So normally what I do is that I aspirate them, I send them off for cultures, I wait for the cultures to come back, and I wait for the what bugs, what organism comes back, and also the sensitivity of the organism. As I said earlier on, for the hips, I'm starting to do more and more like a single stage revision. It's actually called a Kuma's construct, basically custom made articulating cement spacer using an exeter stem and a standard polyethylene cup. So once I get an organism, let's say if I get a Staphylococcus organism, Staphylococcus aureus organism, which most of the time it's vancomycin sensitive. So once I get sensitivity, because there are only few antibiotics that you can add in bone cement, as bone cement undergoes an exothermic reaction, and most of the antibiotics die, but there are few heat sensitive antibiotics like vancomycin, ceftazidime, tobramycin, meropenem, which we routinely use in bone cement. But I think targeted antibiotics is the best. So I routinely aspirate the hip, I get an organism, and then I target the whichever bacteria is sensitive. I put I put the antibiotic into the bone cement. I put a minimum of 4 grams per cement pack, which is 40 grams of cement. And I add a bit of gentamicin liquid in that as well, just to get the consistency of the bone cement better. And then I do a well-fixed cemented cup, as well as a well-fixed cemented stem. And then depending on what organism, I treat them with IV antibiotics for a minimum of 2 weeks, and then oral antibiotics for 3 months, and for 6 weeks to 3 months. That I'm guided by my infectious disease team, which are very good in this hospital. So that's with regards to the hips. But also, if the infection is very bad, or if there's a fungal infection, then I try and do I contemplate of doing a 2-stage revision, either using an articulating cement spacer or a non-articulating cement spacer. But I'm doing more and more single stage Kuma's construct for the hip. With regards to the knee, my algorithm or my protocol is the same, really. I try and get an organism. And then for the knees, I routinely do a 2-stage revision, because I think the hips are more forgiving rather than the knee, because the soft tissue in the hips are better than the knee. So for the knees, I routinely do a 2-stage revision. I try and do an articulating cement spacer. Again, then I treat with IV antibiotics for 2 weeks, and oral antibiotics for 6 weeks to 3 months, depending on the bug that I culture pre-op and intraoperatively as well. And then later on, after about 3 months or so, once the infection markers are normal, and the knee or the hip, the knee is quiet, then I go back and do a second stage revision. And at the second stage revision, I still get intraoperative cultures. I wait for a week. I give the patient at least an antibiotics for a week, just to make sure we don't find any unexpected findings or incidental findings of positive growth at the second stage. So that's how I manage this patient. And also, mean, I've seen a few fungal infections as well, which has been referred to us from outside as well, and these are more difficult to treat. And with fungal infections, I tend to do a two-stage revision, and they need antifungals at least for longer than antimicrobials for bacterial infections. Of antifungals, normally the ID physicians here, we give for about 6 months to sometimes even 9 months as well.
Okay, that was a very well put together answer from covering the history taking to actually covering the culture sensitivity. So we'll move on to the next question. How do you approach the challenges of soft tissue balancing in revision knee and arthroplasty? And when dealing with severe collateral ligament insufficiency, what are your indications for choosing between the constrained condylar design versus rotating hinge prosthesis?
So I think uh, revision knee, when I do a revision knee, I again, I think clinical examination is very important, as well as your radiographs, really your plain. For the knees, I think most of the time you don't really need a CT scan. The hips, the acetabular defects, I normally get a CT scan. But for the knee, I think especially your examination, clinical examination, and plain radiographs are okay. But when I do a revision knee, I routinely get a condylar constrained knee, uh, and as well as a rotating hinge knee on standby. So if the clinically, if I think the MCL or medial collateral ligament is intact, but the LCL is lax, I think those kind of knees you can get away with using a condylar constrained knee. Sometimes if the MCL or medial collateral ligament is doesn't have a firm endpoint, or it's completely torn, or if the patient has got rickevatum, so all the posterior structures of the posterior capsule is lax, and then you have to go for a rotating hinge knee. But in these cases as well, obviously I'll get my augments on standby as well. So augments as well as cones on standby as well. And so these are the strategies essentially.
Okay. So, could you share your experience with managing complex acetabular defects in revision hip arthroplasty, specifically when your algorithm for choosing between trabecular metal augments or custom triflange components and cage constructs?
Okay. So again, with acetabular defects for revision hips, so as long as you're happy there's no infection, and for these kind of cases, the acetabular defects, I routinely get um, a CT scan of the hips. And with regards to acetabulum, I normally classify them as either a contained defect or uncontained defect, or whether there is any pelvic discontinuity. So I think if there is a contained defect or uncontained defect, the management is slightly different. If it's uncontained defect, you want it to become contained, and then you can do something about it. So it's quite complex actually. So I how I manage that, if there is like a structural defect, I use acetabular augments to get the structure of the acetabulum in control. And then I do a combination of a few things. Sometimes if the structural defect, you can put an acetabular augment, and you can put an uncemented cup in that. Sometimes you need to put acetabular augment, then you can put impaction bone grafting, can cement a cup. And if you think it's a contained defect but it's slightly uncontained defect, you can put impaction bone grafting, and you can use a cage. But sometimes even a cage is not sufficient, because in the cage you need to get some kind of stability as well. You need to make sure you get your screws in. And if the defect is very, very bad, then you can use custom made acetabular implants as well. But obviously cost is quite an issue as well. So if the cost is not an issue, then we can use we use acetabular custom made implant like triflange or materialized. But most of the time, if causes an issue, then we try and solve the problem by a combination of acetabular augments, impaction bone grafting, and a cage. So and sometimes you may need to use meshes as well. So if there's like a posterior wall defect, you can put a mesh, impact bone graft, and use a cage. If there's a medial defect, you can also use a mesh on the floor, impact bone grafting. But mesh on the floor, I don't use it much. I just impact it onto the fibrous tissue low down on the floor, and then I use a cage. So there are a variety of methods that we can use to deal with this severe bone defect. But essentially, I use a lot of impaction bone grafting, especially in younger patients, just to build up their bone in case they need further revision later on. But if it's not too bad, sometimes you can just use an augment with an uncemented cup. But if the defect is quite good, you can also use an augment with a cemented cup as well. So I play around with it depending on my intraoperative findings. But most of the time with this severe cases, I always have different plans. So I've got my plan A, plan B, plan C, and I make sure I've got all the components on standby, where I get the reps or the implant companies to bring in all the implants just in case you're caught off guard. And sometimes it's more complex than what you think or what you find on your scans, really. So and the problem is that you do not want to be caught off guard while you're operating in theaters. So so you need all this treatment strategies or this treatment plan as well. And we are quite lucky here in our university hospital, because we have got all the equipment needed for revision hip and knee, as we have been doing it for a very long time, and we have got a very good joint reconstruction unit team as well. So we're lucky in that way. But essentially, this is the treatment strategies for dealing with severe bone loss in the acetabular component.
Oh, thank you so much, Dr. Veenesh, for sharing knowledgeable insights with us. It was an honor to have a conversation with you regarding all the revision arthroplasty. And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers or participate in meaningful discussions and contribute to the ongoing evolution of healthcare. So until next time, stay healthy, take care.